Thank you for the introduction and welcome to Iowa City. It's great to see so many people here today. As mentioned, I'm going to be talking about hormones. I'm a hormone doctor and endocrinologist by training, but I've been focusing on folks with neuroendocrine tumors for some time now. So I'm going to be talking about the endocrine in neuroendocrine tumors. We're going to be talking about, I'm going to define some terms that we use in nets, talk about which nets produce which hormones, talk about what various hormones can do to a person, and importantly how we block the effect of those hormones, either with treatments that focus on any hormones, because there are many hormones, or treatments that focus on a specific hormone. And then we'll be talking about treatments for other endocrine disorders, other hormonal disorders that can come along with carcinoid tumors. So the definition part, physicians, I guess every profession has its own list of sort of terms that make it obscure for anybody outside the profession to know what the heck they're talking about. And certainly the medical profession has plenty of terms that where there are two or three terms for one thing, or there are two terms that sound very alike but they're not alike. So just to get up to speed on the definitions, and there'll be more definitions through the talk. Endocrine refers to it refers to glands in the body which produce hormones, and those hormones, those chemicals, get into the bloodstream and do things in the body. So what is a hormone? A hormone then is a chemical produced by an endocrine gland, gets into the bloodstream, and it causes some symptom or some change in the body. And examples of that might be insulin, which comes out of the pancreas and drags down gets the sugar out of your bloodstream and puts it into storage areas. Serotonin, another hormone that we'll be talking about. So hormones are different than tumor markers. You may have heard of tumor markers or biomarkers. They're chemicals that are produced by the cancer cells or cells around the cancer cells, and those chemicals give us information about the cancer, how aggressive it is, how much cancer is there. So an example of that some of you may have heard about is chromogranin A. It's not a hormone, it doesn't do anything, it doesn't give any symptoms, but it is a chemical marker. You'll hear talk about functional tumors and non-functional tumors. So functional tumors are tumors which produce excessive hormones and where those hormones cause symptoms, because non-functional tumors either don't produce any hormones or they don't produce quite enough of the hormones so that a person doesn't have any symptoms related to those hormones. What is a syndrome? We'll be talking about syndromes a lot today. Carcinoid syndrome, Cushing's syndrome. A syndrome is basically a set of symptoms or physical changes in the body that occur related to hormone excess. Examples are the carcinoid syndrome, which we'll be talking about, which is significantly related to serotonin in the bloodstream, or Cushing's syndrome, another syndrome that's caused by cortisol. So let's go to the endocrine system. The endocrine system refers to a number of glands in the body, and you've heard about some of these glands: the thyroid gland, the adrenal gland, the ovary, the testis, making various hormones. So these glands in the body are physical structures. The thyroid it's a bow tie, and it's about 2 inches by about 1 inch across, there or thereabouts. So it's a physical structure that can be seen. However, there's another endocrine system in the body, another hormone-producing system in the body, which is called the diffuse neuroendocrine system. And it turns out that there are multiple tiny cells throughout the body in various places, just as Dr. Maluccio mentioned, that are actually are capable of making hormones. They're present in pretty much in most of the glands and organs in the body. If we were to take out a sample of, say, the intestine, which you might have done with a colonoscopy, what the pathologist would see under the microscope would be colon cells in blue here, and very occasional cells that produce serotonin, which is in darker brown here. And if they were to pull out one of these cells, it would look like this, with little buckets of serotonin waiting to be produced. Now, these are small things. You'd have to put 2,500 of them together to have an inch. So any of those neuroendocrine cells can produce a tumor. So we can have a variety of tumors all throughout the body. I've highlighted some of the major tumors that we're going to be talking about today, the major tumors that people have, but the lung, the pancreas, the small intestine. But there are many other tumors that are present in lower percentages. For example, a very rare tumor, Merkel cell tumor, is a skin neuroendocrine tumor, and there are various tumors like that are very rare. I do want to just come back to the issue of definitions and the fact that there are more terms than one for most things in medical parlance. And just mention to you that Dr. Maluccio mentioned foregut and midgut and hindgut, and these are old terms, and they can be quite confusing because foregut actually, while pancreas is in there, stomach is in there, actually lung is part of the foregut, which doesn't seem to make any sense at all. Midgut, the midgut includes most of the small bowel, and this is the most frequent, the sort of single most frequent tumor from the ileum, so that's in the midgut group. The hindgut group contains that rectal tumor. Then there are you'll hear people talking about gastroenteropathic net or GEP net, which is basically any net in the gastrointestinal tract or the pancreas. People will shorten up pancreas neuroendocrine tumor to PNET, small bowel neuroendocrine tumor to either SBNet or SINet. So very confusing, but these are the terms. Let me get back to hormones. So the issue is that different hormones come from different tumors. So while most of these neuroendocrine tumors, irrespective of where they come from in the body, share a lot of common features, and then sometimes a pathologist who's not very experienced will have difficulty in knowing the difference between a pancreas neuroendocrine tumor and a small bowel neuroendocrine tumor if they don't know where it's actually been taken from. One of the other differences with neuroendocrine tumors is that different tumors can generate different hormones. So we have the lung there on top. It can make serotonin, it can make histamine, it can make a hormone which causes the secretion of cortisol. Stomach can make histamine. Pancreas makes a whole raft of different hormones. At least a half a dozen different hormones can come from the pancreas, including things like insulin that you've heard of, glucagon that you might have heard of, VIP that someone in this audience has heard of, but maybe not many have heard of. And then small bowel neuroendocrine tumors, the big 800-pound gorilla that comes from them is serotonin. So different tumors produce different hormones produce different syndromes. So with serotonin, it's producing the carcinoid syndrome. With the histamine, it's producing what I call an atypical or unusual carcinoid syndrome, and I'll give you a picture of that. With the pancreas, there are a whole slew of different syndromes, insulin-producing, glucagon-producing, gastrin-producing. With small bowel producing serotonin produce the carcinoid syndrome. Neuroendocrine tumors on the adrenal can produce pheochromocytoma. Different tumors, different syndromes, different symptoms. So each of the different syndromes has different symptoms. So the classic carcinoid syndrome is flushing and diarrhea. 80% of people who have carcinoid syndrome have either or both flushing or diarrhea. I'll show you what an atypical flush is in a moment. The other syndromes in the pancreas can produce either very severe ulcers in the stomach, or low blood sugars, or diarrheal issues, or high blood sugars, as you see here. So there are a lot of them, and then the carcinoid tumor we've talked about. Typical flush, atypical flush, just to the typical flush with a person with neuroendocrine tumor, sort of a small bowel neuroendocrine tumor perhaps, is redness of the face, maybe forehead, maybe upper chest, lasting maybe 3 to 5 minutes, associated with a feeling of hotness. In people who have very severe and recurrent severe flushing, they can almost take on this purplish hue and this beetroot red skin. An atypical flush, however, such as one that comes from the stomach, might be this: patchy across the body, lasting for many hours at a time, maybe associated with other allergic type features because it's histamine driven, such as swelling of the eyes, or even hives. So, sort of a summary slide on nets and syndromes. The frequency of the syndromes varies with the site of the net. So when we're talking about nets and syndromes, about 20% of people, when they're diagnosed, will have, say, carcinoid syndrome associated with their small bowel. But that number can go up to approximately 60% over time as these carcinoid tumors grow. So the amount of the tumor can increase the number of people who have the syndrome. In the lung, about 10% of people will have carcinoid syndrome at the start. Some people have Cushing's syndrome from excessive cortisol. And in the pancreas, again, about 20% of people have some syndrome, but that's divided amongst a group of different syndromes. So there's relatively few people who have any given syndrome. So how do we take care of these issues? I'm going to talk about therapies that will be helpful for all the different syndromes initially. And Dr. Maluccio really set this up nicely, talking about the various therapies. And so, as a patient, one is eventually diagnosed with a neuroendocrine tumor and has a grade assigned from the pathologist and a stage of the tumor, the degree of spread assigned from the radiologist, and then gets into a situation of treatments. And Dr. Maluccio has already mentioned the surgery, somatostatin analogs that we'll talk about, liver therapies, embolizations, PRRT, drug therapy, and as Dr. Maluccio mentioned, you'll have talks about all of these. So therapies for these syndromes, one way to get rid of the syndromes is to remove or kill off or decrease the amount of tumor tissue, and you can do that by most of these treatments. So surgery, embolization treatment, PRRT, certain forms of chemotherapy that shrink tumors. If you shrink the tumor, you will decrease the amount of hormone coming from tumor and therefore decrease the amount of symptoms. I'm going to focus on the one in the middle because that one, the somatostatin analogs, this is the practice of using a hormone to control the hormones. So somatostatin analogs decrease the production of all of the hormones from a neuroendocrine tumor via that parking space, that docking space that Dr. Maluccio mentioned, the somatostatin receptor. Somatostatin and somatostatin analogs. You might hear people talking about somatostatin analogs or SSA. Somatostatin was discovered in 1979. It's 14 amino acids in a particular structure. Each of these three-letter terms is an amino acid. An amino acid is just the breakdown product or the building product of a protein. But somatostatin has a particular characteristic sequence of amino acids on this rounded end, and that's the sequence of amino acids that gets into that docking space, that parking space that activates the somatostatin receptor. So the folks at Novartis in the 1980s developed octreotide, because the problem with somatostatin is that if you had an injection of somatostatin, it would not last in the body more than a few minutes. So that's the problem with native somatostatin. So octreotide was initially developed, and this is what many of you are taking as sandostatin. Had much longer lasting effect. You can see that the active part is the same. Ipsen came out subsequently with lanreotide or somatuline, which many of you are on, but keeping that same structure, which is the structure that activates those receptors. Dr. Maluccio has elegantly described the concept of hormones and docking sites, but so these hormones are in the bloodstream, are after your injection. They get out of the bloodstream. They attach to the parking site, and they do two things. They essentially tell the tumor to stop making hormones, and they tell the tumor to slow down the growth. So two things happen. And I don't want to give you a lot of data slides, but we can show that they work, and they've been shown to work in various different ways. So this is a slide of a group of people, about 40 people, some of who were given short-acting injections of octreotide, some given long-acting injections of octreotide, and their carcinoid syndrome, as judged by their bowel frequency, went down. And we could show the same slide for flushing, and we could show the same slide for the effect of lanreotide. In fact, this is a slide in a different study of lanreotide, the other monthly medication or 4-weekly medication that many of you are on. And this took a group of people who were either getting placebo or getting lanreotide and measured their urine 5-HIAA. So some of you have done a 24-hour urine collection. This is what it's for. HIAA is the breakdown product of serotonin that comes out in the urine. And it shows that, yes, indeed, lanreotide does decrease the hormone production. And this is a historical slide. It's a slide that Bob, when he introduced the talk, mentioned Dr. Odorizio, my late mentor. But it's a slide that of a patient that he was involved in taking care of in the early days of octreotide. And it's a slide that shows that this person with VIPoma, VIP-secreting pancreatic neuroendocrine tumor, when treated with octreotide, and they only had short-acting octreotide at the time, when treated for about a week of octreotide, all of the hormones produced by the tumor went down, including the VIP, and the very severe diarrhea cleared up at the same time. So these agents decrease hormone production from all of the tumors. I told you that these agents do two things. They stop the hormone production, and they decrease the rate of growth. And this was from a large study of lanreotide, showing that people who were put on placebo and followed out over time with CT scans, they started getting increase of their tumor by about 18 months. Whereas the people who were given lanreotide their tumor didn't start growing again until 33 months. So an important concept with these agents is that we do have an FDA-approved dose. It's 120 milligrams for lanreotide. It's 30 milligrams for sandostatin. But what we're seeing is that going above the dose can be very helpful for people who still have some syndrome, carcinoid syndrome, or other symptoms. So this was a study where they took about 200 people who either had flushing or diarrhea. They increased the dose over and above the FDA-approved dose and determined whether their symptoms were improved or not over the following year. And basically 80% of them in this retrospective look-back study did better. And we do have new studies that are prospective, that are much more controlled, and have shown that lanreotide, for example, can inhibit tumor growth when given every 2 weeks rather than every 4 weeks. So this is a very legitimate thing to think about. So some practical ways that I approach the treatment of the syndromes with lanreotide and octreotide is that I will start off the octreotide or lanreotide at a lower dose. In people who I think might be very sensitive to side effects, I'll start them off at 20 milligrams of the octreotide or sandostatin, or 60 milligrams of lanreotide or somatuline, going up to the FDA-approved doses. And I'll increase the dose if there is insufficient control of symptoms, or if people tell me that in the last few days of their 4-weekly cycle that they're getting new symptoms, that they're getting the flushing and they're getting the diarrhea in that last few days of the cycle. Actually, I think this is a very important thing, because many people tell me that they get some of the symptoms in the last few days of the cycle and say, yeah, it's not a big deal, I can take some Imodium, it's not a big deal. Well, it may be a big deal, because remember that sandostatin and lanreotide do two things. They stop the hormone production, and in parallel, they decrease the tumor growth. So if we're not doing a great job with the hormone production and the symptoms, we may not be doing as good a job as possible with the growth. So I don't like to see people having symptoms, because I'm worried about perhaps the more important issue, which is the tumor growth might be uncontrolled as well. Increase the dose by either increasing the amount. We can go up to 60 milligrams of octreotide. We could go higher, but that's usually as high as I go. Or we can decrease the interval. We can go to 2 weekly. We can go to 3 weekly. Now, some of those 2 weekly and 3 weekly things are difficult lifts with the insurance company. So I spend a lot of time on the phone trying to persuade insurance companies to allow people to go to 3 weekly or 2 weekly if they're having symptoms. Sometimes the insurance company won't go for the 3 weekly, but they'll allow supplementary, self-injected, short-acting octreotide. And if that's the case, I get people to take that in the last week of their 4-week cycle. If they have the symptoms. And I start at 50 micrograms to 200 micrograms. There are a number of different concentrations of octreotide, the short-acting medication. I use the strongest concentration is 1,000 micrograms per mil. Try and get that one, because it's less painful than 100 micrograms per mil, and I think, frankly, it works better. And the gastrointestinal symptoms which may occur with these agents can be taken care of by a simple pancreas enzyme for the most part. Let's talk about some other treatments. That was a treatment that would work on any of the syndromes. There are some treatments that are focused on just one of the hormones, including a relatively new treatment over the last few years. But one of the things that you can do is to try and identify. Some people have triggers for their symptoms, either their diarrhea or their flushing, and identifying those symptoms can be very helpful, because if you can avoid the situation, that gets you out of the symptoms. Or a person could take a shot of short-acting octreotide just 30 minutes before exercising, or having a large meal, or having a glass of alcohol, and that would tend to take care of those that flushing and diarrhea episode. Dr. Maluccio mentioned dietary advice. Some people notice that certain items in their diet can stimulate the symptoms, and those items of the diet include anything that's aged or cured or smoked or yeasted or fermented or alcohol. And so in many times these foods contain tyramine, which can stimulate the production of hormone from these tumors. So for some people, working on the diet can be very helpful. This comes from a book by Dr. Go and Leanne Burns. Leanne Burns used to be the dietitian at the New Orleans group, has a lot of lectures online and very helpful advice. Do we have anything else to decrease the carcinoid syndrome? Well, carcinoid syndrome, as I mentioned, is significantly, although there are a lot of hormones that can cause parts of it, serotonin is the big one. It's certainly the big one for the diarrhea. It's not quite clear what's the big one for the flushing. Serotonin may have a role in that as well. Serotonin is the big cause of heart disease in carcinoid syndrome. So there's a new medication, relatively new, that specifically blocks the effect of serotonin and can be used alongside the octreotide or lanreotide. It's called talotrostat. And just to explain how this works, when we eat, the protein gets broken down to amino acids. The amino acids then get either built up into new protein. Some of them go to become other substances, such as the vitamin B3 niacin, and about 1% of the tryptophan goes to serotonin in the bloodstream. However, in carcinoid syndrome, perhaps 90% of it goes to produce serotonin, so a person can get a niacin deficiency, a person can lose weight because they don't have enough protein to build up. The newer medication, Zermello or talotrostat, is a medication that blocks the production of serotonin. So with that blockage of production of serotonin, it successfully decreases the diarrhea. And this is just over time of over 12 weeks, a study where people were given 250 milligrams 3 times a day of this agent. Not only decreases the number of times a person has a bowel movement, but it also decreases the urgency as well, which is important. So this medication is used in addition to the octreotide. It's usually taken with food. If it works really well, it could cause constipation, and if that happens, stop. It does have some side effects. I find that it has relatively few side effects, and I find that if people start slower, maybe just 1 tablet a day for a week and going up like that, people can tolerate it better. However, it may take 2 to 3 months to see the full effect of this medication. So it's not exactly the same as lanreotide and octreotide. They both decrease serotonin, they both decrease diarrhea. This one doesn't decrease all of the other neuroendocrine tumors, hormones. This one, octreotide, decreases flushing because it decreases all hormones, whereas this probably not. Carcinoid heart disease, this is a major area for research as to whether this agent can decrease the risk of valve disease in the heart. Decreases tumor growth. This is another important area of research on serotonin. Dr. Ear, who works with Dr. Howe, is doing a lot of basic science research on this very question. So this is, we'll wait and see. This, however, octreotide is an injection, and a big injection. Whereas telotrestat is a tablet. One of the exciting things that's happening with these agents now is that we're finally getting some of these agents that will be oral. You will have a tablet form of octreotide or an agent that works like octreotide, and I think I see Crinetics, who is one of the companies developing that medication. We've got a clinical trial ongoing at the moment. One important thing is to remember that not all diarrhea is carcinoid syndrome. There are a variety of causes of diarrhea in a person who's got a carcinoid tumor. One is the carcinoid tumor. We treat that with octreotide. But another may be that they've had their gallbladder removed that needs a different treatment, or that they've got bacteria overgrowing in the bowel and that needs a different treatment. Or indeed that they've got niacin deficiency and that needs a different treatment. Or indeed a person can have diarrhea for any of the 15 reasons that anybody else gets diarrhea, including you may be on metformin for your diabetes. That may be causing diarrhea. So hiking up on the dose of the octreotide or lanreotide won't work for everything else apart from the carcinoid tumor. Are there other treatments? Before we had octreotide, we used to use cyproheptadine, which blocked some of the flushing and perhaps some of the diarrhea. It's really an old antihistamine agent. Many of you will have heard of ondansetron or Zofran as an anti-nausea medication. It's actually an anti-serotonin medication and can sometimes be helpful. I mentioned that some of the carcinoid syndrome can be caused by histamine and can respond to high doses of antihistamine. However, as Dr. Maluccio said, uncontrollable carcinoid symptoms, that's a reason, even if the tumor is stable, that's a reason to consider again surgery or ablation or enucleation or embolization or PRRT. Just briefly, non-carcinoid syndrome. So these are the pancreatic syndromes, and there are a lot of them. They're complex. Maybe I just highlight one or two of them. Gastronoma produces gastrin, that produces ulcers. So we can treat that with high doses of omeprazole or rabeprazole, pantoprazole, that type of medication, and also high doses of Pepcid and sucralfate. So in addition to octreotide. Insulinoma, caused by insulin, causing low blood sugar. We have other medications other than octreotide and lanreotide that will improve decrease the insulin level and decrease the low blood sugar. Just one final pair of slides on something where my practice has sort of changed in the relatively recent past, and it refers again to the folks who have pancreatic neuroendocrine tumors. When I started doing this, I used to tell people that there was about a 5% risk of having a genetic disorder. Well, actually, newer data is showing that 15 to 20% of people who have pancreatic neuroendocrine tumors have genetic disorders. And it's important to know that because A, you can pass them on to your kids. B, when a person has a genetic disorder, they have neuroendocrine tumor, but they'll have more than that. There are other things that need to be watched out for. And three, or was it ABC? I can't remember. Number three is that the genetic syndromes, may have medications that specifically work with those syndromes. So one syndrome, VHL, where there's pancreatic neuroendocrine tumor and pheochromocytoma and a number of other kidney cancer, that has a new medication associated with it, which is now FDA approved for the kidney cancer aspect. And Dr. Chandrasekaran led a study at Iowa and is ongoing using belzutifan in individuals with pancreatic cancer or pheochromocytoma who do not have VHL. One of the common syndromes is NCAN1, and you can see here that apart from pancreatic neuroendocrine tumor, there's lung neuroendocrine tumor, there's parathyroid and pituitary. So there's a lot of hormonology that goes on with these syndromes, and it's important that a person knows about them. So just a take-home message, and I feel like a TV announcer when I say it, if you have a pancreatic cancer, ask your doctor if genetic test might be right for you. And this, I'd like to thank all of my colleagues, and some of you know many of them, and many of them are in the audience today. Kimberly keeps the ball rolling, and Aaron Klein has been working with me recently, and Jim Howe and Scott Sherman has been working with him recently, and you'll meet Dr. Chandrasekaran and Dave Bushnell here. Thank you very much for your attention.